It will be only possible if you do the spirometry. And you must do it, in my opinion. Because that depends on what will be the characteristics. Remember that in the today's lecture, we learned that there is if you give the challenge of medications, what is it called? Yes, if we do metacolin in the sleep deprived patient, it may not be exactly the same. These are good news and information that we got it. So metacolin challenge is not going to be equal like the way normally for obstructive airway disease we provide. So now going back to all the things, because we have to analyze that case rather than just clear that this is what is going on with the patient. Next panelist is going to talk about the relations of the heart and the lungs. He has given the lecture before, but now maybe in a short about this particular case. If you can analyze a little bit, Dr.
From the physiological perspective, in the field of cardiovascular medicine, psychocardiology, we have to look at how psychological risk factors they can basically affect the cardiovascular system. In this particular case, later on we're going to go into the psychiatric portion, might be that when you're asking yourself the question of why this patient is waking up at night, you have to look into the hemodynamic or physiological perspective. It's because he cannot breathe or he's thinking about what happened during the day. When he's ruminating, it's a psychological reason behind he's waking up, or his cycles are affected, or there's some kind of physiological reason that it's affecting the heart and the lungs. So how do you monitor that? Well, in terms of psychological risk factors, we have various scales or constructs that we can follow, including anxiety, like STAT, trait anxiety, anger, depressive symptomatology, and so forth. From the more electrophysiological perspective, into heart rate variability, we can look at diurnal variations in the oscillations of the autonomic function. So what you want to see is that these variations come and go. Probably this patient will have less variation throughout the day, in 24 hours or throughout the week. So as we move that patient into the management and the process of treatment, we want to see that those variations, diurnal variations, start to have gain in amplitude. That can be monitored using various devices. One simple example could be using a biopatch. Probably is a device about this size, and it attaches ECG electrodes, and you can simultaneously monitor ECGs plus respiratory rates. The other aspect from the physiological perspective to take into consideration, if the patient has these sleep disturbances and have the history of hypertension and other pulmonary system involvement, I would like to take a look at the subject myocardial variability ratio as a normal marker, which is a marker of coronary perfusion. Those variations during 24-hour cycles are very important to be considered. And lastly, also the patient, him or herself, in this case him, can look into a more sensitive way to do journaling. So for the most part, in the last years, we give paper, and the patient has to report, well, I ate today, I don't know, I went to the market, supermarket and I ate 2 sandwiches. And that night, that patient slept well or slept well. So you can start doing some kind of associations. Now we have tracking devices that we define for specific outcomes. That's to say, in this particular case, I'm sleeping good, I'm not sleeping good. And then you can track using a keychain and an app, basically what kind of activities you're doing throughout the day. This is in the perspective of psychological risks. In the perspective of diet or lifestyles, you can also add those into the built-in into the app. So in that way, the patient can also, when it comes back to the clinic, can have a report that can show to the physician and say, you know what, probably part of the reason you're not sleeping well is that you're eating too much of these kind of nutrients that probably is an allergy, probably something that is causing inflammation to the airways, and a very good way to depict that or basically to tease out what is causing that is journaling. And we have electronic ways to do that these days.
But this is definitely gives some information that this particular case can go into a long discussions. But we know that our time is limited. So we are going to do the sleep study on this patient. And this patient has sleep apnea by the assessment of the sleep study. But what I'm trying to put into the thoughts in everybody's mind is that this patient can be only having sleep apnea, but there may be underlying cause, and those underlying cause has to be investigated. Now, the patient may have sleep apnea, but the patient also have tremendous another components, which is actually in this particular case, the patient have restless leg syndrome. And also the patient looks like this patient may have some kind of anxiety underlying. So we wanted to know about restless leg syndromes and how we get into that one. It will be briefly discussed by the Dr. Said. And Dr. Marcos adequately talked about the parameters that we will look into that. But it is also very important to know that you don't have to have an invasive procedure to analyze somebody's pulse pressure. You don't have to have an invasive procedure to figure out what is the patient's cardiac output is. You understand? Why? Because your physical examinations can provide that with the proper pulse ox and also with the ability to do if there is a pulsus paradoxus going on or not. Pulsus paradoxus is not easy to be assessed. It has to be by the blood pressure. Remember, it is pulse, but it's pulsus paradoxus. So if there is a pulsus paradoxus is going on, you can assess that by your own physical examinations technique. I'm sure you know about that. If there is a compensatory mechanisms is going on, you will be able to assess that at the bedside. And next things briefly, we must know about restless leg syndromes because this is a new things, and then it will be done by Dr. Said, and I will not intervene. After that, I will ask the main person who is going to conclude that it is a anxiety. What is the take-home lessons about the anxiety disorder as well?
So I also want to apologize about the slides that you have in your handout. Actually, there was a little miscommunication, misunderstanding on my part. What I'm going to talk about. So I have the slides. If you would like, I'll be more than happy to email them to you. So we'll talk about restless leg syndrome. Let's see. All right. So again, I'll mention that my mother suffered both from restless leg syndrome as well as insomnia. So again, this topic is very heavily tested for the pharmacist NAPLEX exam. So again, we pond a lot on this topic. So again, I will start with some brief history. So this term of restless leg syndrome was coined by Carl Ekman, and then it's considered as a sensory motor symptom, and then they're usually felt during the wake state. And then this was described, a long time ago by English physicist, physician Thomas Lewis in 1672. So Ekman actually did a epidemiological study, and then he concluded before 95 that like 5% of the population has disorder. But recent studies show that about 5 to 15% of the population do suffer from this. And last night actually I checked at National Institute of Mental Disorder, and they mentioned that about 73% of the American population do suffer from restless leg syndrome. Dr. Lourdes touched upon this a little while ago. So iron deficiency has been noted in almost every patient that has restless leg syndrome, except for a few exceptions. So and studies have shown, there's a reduced iron level in CSF. And then if you look at the MRI, the section of the brain, glutamate substantial agra, will show lower iron level. That was an interesting study published by Boragor et al. In 2002. They noticed that the patient who actually were going through restless leg syndrome, if you draw the blood, you will notice that there's a 50% reduction of free iron in the blood. So that actually it's a very interesting topic. If you look at pharmacology journal, I mean, it's still why iron deficiency causes restless leg syndrome is still being studied. We don't have a definite answer, but it's still that's a highly investigated area. So also during pregnancy, about 11 to 27% of the female will experiences RLS, and this will go away by itself without any intervention after giving birth. About 20 to 50% of the dialysis patient will also suffer from restless leg syndrome. And then people who have hypothyroidism and diabetes will also sometimes complain of RLS. And RLS has been also noticed with patient with rheumatoid arthritis and suffering from Storm syndrome. So again, as I mentioned, we don't know exactly what causes it, but the current literature actually points to the malfunctioning of hypothalamic event-opening cell. So what happens is their job is to actually modulate the dorsal nucleus. The A1 cell actually project caudally towards the dorsal nucleus, and then they quit their activity. Now, if those cells are gone or not functioning properly, then we have enhanced sensation and urge to move. So, how to diagnose RLS? The patient will have urge to move lens, and then associated with paraendodysphagia, and usually symptoms worse exclusively present at rest. And then, sometimes the patient will get up and walk and they will feel better. And then symptoms usually become worse at nighttime. And these patients will respond very well to dopaminergic drug like levodopa. And then, they have periodic movement during sleep, and they often have positive family history as well. So again, Dr. Lourdes touched upon it. So again, I'm just enjoying. I was listening to her talk. So if you look at the survey, what patient would describe, they would say that I feel like electric current going through my legs. Like I feel like my legs are going crazy, or like soda is bubbling, or Coca-Cola is bubbling through my veins, aching in my bones, and somebody's pulling my legs, and then it's feeling like tearing. Sometimes these symptoms are pretty strong, feeling like throbbing and crawling, like Dr. Lourdes showed. That child draw a picture of ants crawling on the leg, and then growing pains and itching bones. So these are all the terms that patients have used to describe their restless leg syndrome. So how do we treat restless leg syndrome? That depends on exact physiology. So patients who have iron deficiency, giving them iron supplements does help. And then sometimes just before they go to bed, a light activity. Now you don't want to work out heavily, then that will just wake you up. So light walking, brisk walking, stretching, taking cold or hot bath depending on person, and then not coffee actually or stimulant. And then as I mentioned, levodopa actually does very well with patients suffering from RLS, but then levodopa causes augmentation and then aggressive behavior dissipation. And in some cases, opioids have also been used, and as I mentioned, iron supplement does help. And I was looking at the National Institute of Complementary and Alternative Medicine. Surprisingly, patients with RLS do very well with St. John's wort, but you got to be careful with St. John's wort that induces enzyme. If you're taking another medication, you got to be careful with that. So I'm just going to stop right here. I had a whole talk on a lot of sleep disorders, so I don't want to make this movement here, but if you have any question, I'm more than happy to delve into
We are, because of the time, we are going to go into that, the components of the psychiatric element, but one of the most important one here is that Dr. Zirov will be able to shed some light on this particular patient's anxiety-related disorder.
Hello. Hi. Okay, so here again, I was saying, it was my presentation on the sedative hypnotics. I talked about it in the previous lecture. And you see, this is very important because of the fact of what this patient is going for. Okay? We see him sometimes as the Antichrist, but in reality, we see choking. The patient is choking. We don't know why. It's being evaluated by the primary care physician. It's one of the symptoms of anxiety, right? Being that said, I have a patient in front of me. This patient comes to me, I have to see the whole perspective. This is something new, something that has recently started. Now we know some things about the patient, as syndrome, a possible, fibrosis or hypertension on the lungs, which is causing the right side of the heart, strain, hypertrophy, whether or not. And you have this individual in front of you who has very bad lifestyle behaviors. This individual smokes, this individual drinks, which are substances that will predispose to insomnia, predispose to anxiety disorders, and all whatnot. But at the same time, this behaviors are one which, with the obesity, he has a history of COPD, smoking. This individual is probably also maybe having some reflux, causing aspiration, causing fibrosis to the lungs, and it becomes very challenging to treat, okay? And whatever or not is happening there causing these symptoms, you might say, okay, let's go for the benign thing, let's go for a trazodone, let's go for a metazapine. Well, metazapine will alleviate these having jerks, symptoms or whatnot, but could contribute to obesity. At the same time, trazodone, any anticholinergic, which you might think is pretty benign, is going to cause, let's say, your electron node to be affected. You have the long prolongation of the QT. You could predispose to sudden death that Dr. Alvin was talking about, just with your benign vinegar. Okay? So, basically, he was taking a boost bar. The thing about boost bars is that increase the respiratory center of the hindbrain, the reaction to CO2, which is having a lack of because it's respiratory problems, but at the same time it can cause insomnia. This is a very difficult patient. You have to treat as a whole. The restless syndrome, why is he having anemia? Why is he having anemia, right? Like to say, he's a man. Then let's look for that. He's having reflux. Tears, he drinks, lower GI bleed. What's going on here? How's his kidneys? Well, this is being, all treated, and we're looking, to get to the bottom line of it. At the end, this patient had a previous episode of major depressive disorder, and is at risk of developing, psychiatric disorder again. This anxious, type A personality, stressful job, of getting more anxious and totally compensating. And the reality is that while these things, are being addressed by the PCP, and at the same time, we are, trying to have the patient without having modifications in sleep. And the safest thing to put at this time, if we're not getting symptoms of depression, which we did for depression, like there's some little bit of anxiety component there, is to put the patient to sleep. A sedative, a hypnotic will be pretty safe, okay, the short term, while other things are being addressed because treating this type of patient needs a multidisciplinary team, okay? So I think that, treating the insomnia per se, we're going to decrease any anxiety, treating it with a hypnotic, even, for example, an Ativan, a little dose of Ativan affect the heart, decrease the blood pressure, okay, versus other things that might precipitate that. A C drug, just initiating sleep, short-term, short half-life one, or something like messed up, long half-life, but will help the patient to sleep, and while the restless leg syndrome is being addressed, the patient can rest and not continue to have frequent awakenings throughout the night. That's what I think.
Well, this is a clinical case without any end. So it is not the destination that I was looking for. I was looking for the process. And I think not including me, other than me, my panel did an excellent job. Just give the floor. Now the question and answer. If you have any question, please come forward and let me see who actually you're addressing to, and we will try to answer that. Any question? All right. If there is no more questions, one more time. Oh, go ahead.
Dr. Furr, do you find that patients who have Asperger's have sleep difficulties and/or mental difficulties that you need to do different anxiolytics for? I mean, I've had a few patients, they gravitate to me, I guess, and they have a multitude of problems. And I thought sometimes that they might have sleep disorders, but I never pursued it. So now I'm wondering, in your experience, have you seen any of that?
Yeah, for sure. As the previous presentation, the pediatrician, somebody with that, okay, autism spectrum disorder. All of these psychiatric disorders, intellectual disabilities, they come in a cluster of disorders. It's not just one. So a lot of them have ADHD, which is, when I was saying the previous presentation, is something that highly predisposes even infants to insomnia. Okay. Some of them have comorbid bipolar disorder or some type of mood dysregulation disorder. Okay. Anxiety disorders, there's a lot of anxieties that they have. Basically, yes, it is a disorder like we were saying before, autism spectrum that, they're going to have some type of distorted circadian rhythm and cycle. And it's hard to treat. Sometimes, it's just minor things. You can use the melatonin, which is lacking and it helps. But sometimes you need a little bit more, and sometimes you need to address the anxiety that the patient is having, because that's what it differentiates. Just the patient can't fall asleep because there is an embedded problem in the brain, or is it that the patient is so anxious? And that's why sometimes you give an anxiolytic, which is not a strong hypnotic, and the patient's sleeping. Oh, I've been sleeping with that, with a little bit about it. It's because it was the anxiety that was causing them not to sleep. Sometimes you need multiple, because sometimes there's a dysregulation, of making that melatonin because of the patient. Cerebral palsy, somebody that had a hemorrhage and St. John Gate and cerebral palsy and responding to a light, stimulus and all that, and you might need a Nesta, Wamfazine, and on top of that, a sedative, to try to combat patient down and go to sleep.
Any other questions? Thank you, Dr. Jasmine Ahmed, Dr. Saeed Rizvi, the Associate Professor of the Hampton University, Virginia, and Dr. Gerald Ferrer from the Larkin Hospital, Program Director in the Psychiatric Department, and Dr. Marcos Sanchez as the Vice President and the Research Director of the Larkin Hospital Academic Affairs. thank you, all of you who listened to